So one of the first themes that I wanted to ask the rest of the panelists about is this idea about embedding behavioral health into the idea of the mission of your clinic or your clinical organization. Can you talk about what you needed to do as a leader yourself and the other leaders around you to make sure that behavioral health really was a core part of the way you deliver care?
Yeah, so I think that it's not intuitive for practices to embrace it as a core value. I think, like I heard someone mention that you burn the bridge behind you, though. Once you've entered into the model and you've found some level of success, it's hard to imagine going back. So once we had a behavioral health component to our practice, it became very natural. I very quickly, and my partners, my physician partners, very quickly realized this was an integral service, and we ended up we pay more money for this service. So think about that. We actually, technically on paper, we lose money in this deal. I think we probably, if you actually could account for all the costs, we probably win in the end. I know that the patients win in the end, and I really think that the practice feels, I mean, I don't know, kind of cheesy, but we feel proud of ourselves. We feel like we're able to kind of provide comprehensive care in a way that maybe we weren't doing, 5, 10 years ago. Maybe a lot of other practices are still aspiring to. So.
Awesome. Well, we have a great group of physicians who, from the minute we laid eyes on Betsy and Susan, we knew we were never going back. And so we're kind of at a break-even, point. We have a really great deal with Families Plus. Moving forward, we're expecting to lose some money, but we're moving forward regardless. Providing care to our patients, I mean, this is much deeper than I had ever thought that it was going to be. And so being able to move patients over, to see our therapists or really take their care to another level, and our provider satisfaction have significantly increased. It's a really great thing, and we can never go back. Jan, you turn the lights off.
Gosh. I don't think our practice would ever want to go back to not having integrated care. It's definitely changed everything, how the office runs and the procedure from rooming to the testing they go through. It's really changed everything. But I think, when we started, we had the Center for Mental Health and the board at Gunnison Valley Health and the CEO say, we want integrated care. And it was up to me to try to approach the practice and sell them on the idea, already being on the ground trying to make it work. And it has. I'm really happy to say that I can't imagine it any other way with my colleagues there. So I think there's huge buy-in, even though we were told by the uppers this was how it's going to be. We have buy-in now. So.
Good. So about that buy-in, a lot of times there's reluctance or resistance, as you were saying. That can you think of a time or the example of when behavioral health broke through that resistance, that people said, "Oh, that's what it's supposed to do. That it's making my life better. So now I'm actually gonna buy in." Can you think back to the time before there was buy-in and what kind of made a transition to saying, "Yeah, we're all in"? You don't have to start.
Well, I can't think of the very first time, but there was something that happened just within the last month, and I've been in the practice for about a year now. But within the last month, we finally got the system of doing the PHQ-9, the GAD, the audit, the DAST, and a PTSD screening done with patients annually, at least. And the doctor's response to that and how we got it to interface with the ECR, they were like, wow, this is amazing. And the feedback that we heard at that moment made me realize, yeah, this is amazing, that we are working together and this is the way it should be. So that was just a month ago. So 11 months after we got started.
And for the non-clinical folks in there, those 6 acronyms probably represent about, what, 10 different behavioral health conditions?
So yeah, we're screening for depression, anxiety, drug, alcohol use, post-traumatic stress disorder, and we actually do ages and stages too.
That's amazing. Great. Any other stories that you guys, or anecdotes about when other people saw the value of behavioral health resonate with somebody who was resistant?
Well, I mean, I guess I'd say I kind of agree. I had my own personal, like, aha. I wasn't particularly resistant, but I think on the same day I had 2 potentially suicidal patients who walked in, because of a cough, right? And so, and for those of us who work in primary care, that happens. And I was able to, it was sort of like they should have had the cameras there, right? Because I walked right on down the hall, knocked on the door, said, to my provider then, behavioral health provider, listen, I've got crisis, I need help. And it made obviously it made all the difference in the world. And it's something that would have been so cumbersome had we not been able to do that. As for my partners, I think what you just saw was it wasn't so gradual. It pretty quickly happens that people realize, sure, there is some of who was mentioning the dumping effect, right? There's that, like that. Yes. To some degree, they say, "Oh, wow, I can get rid of all of my, annoying, difficult patients who are screaming, bratty kids," and But I think there was some true sense of, we really want to help these people, and now there was really an actual avenue. Not always perfect, but there was really a way that you could connect them, and then in our EHR, follow up afterwards. There were not all the complete notes, but there would be updates, and guess what also? You're bumping into that person, who said something about bumping, right? You're bumping into that person in the hallway. Oh yeah, Sally, you know what? She's doing really well now that you put her on an antidepressant, and we're, behavioral health counseling is going well, and success. So it didn't take long for the majority of the providers to come around.
Oh, he has a question.
Oh yeah. Was there a question? Yeah, this is what it's for.
That largely relates to workflow, patient flow, and rather than provider satisfaction, patient satisfaction. Obviously, you just described a situation which was a bit of a crisis, a potentially suicidal patient. And I presume your behavioral health colleague was involved with another patient at the time. They don't just sit around twiddling their thumbs waiting. So both from a standpoint of the providers of both kinds, as well as the patient, the knock on the door phenomenon, how have you dealt with that and what have been the outcomes?
So it sounds like the question is, how do you rely on, an emergency knock on the door when someone is also seeing patients during the day and has other obligations? We all, have the tug and pull of time. That is exactly one of the things I was hoping that we would address to some degree, because that is a real problem. We have one person there to rely on. If it is a true emergency, I think that our provider now is accustomed to the idea that, I'm working in this world where an emergency is, the person I'm with is going to understand. I may even brief them beforehand that this is always a possibility, but I want to be able to devote time to you, but also be able to take care of an emergency. So we'll sort that out. We all get knocks as physicians. I know we get knocks on the doors, and we have to kind of triage: is it worth it or not? But I'm with you. I cannot remember precisely how that played out, but that is a problem where a lot of times I want to knock, but I don't quite, because is it quite worth it for the warm handoff? And so I don't know what you guys have thought.
I want to address that. Dr. Sandy, sort of a mentor of our, suggests that we therapists put a sign on our door that says, "Please knock." And how I've handled, I do what's called informed consent, in addition to my professional disclosure, which is required by my licensure. The first appointment, I talk about, in this model, your care here is we care about your whole person, and we have 3,000 patients. So when you're here from time to time, we may be interrupted. And I just put, that's the first thing, one of the first things I say is that, you know, we're not in a traditional specialty mental health clinic where you know, again, the cup of coffee and the couch. So I explain that, and it's happened a number of times to me where I've said, the knock, I go step outside, find out that it's a suicidal patient, so I step back inside and I say, you know, I might need to ask you, can we resume another date, or do you have a good 10 to 15 minutes where you could work on the homework that we talked about? You could do it right here. And I've never had a patient with whom I've been working have a problem with that at all. So, and then I also wanted to address that that twiddling your thumbs thing. So we found that scheduling integrated health counseling follow-ups, the 30-minute follow-ups, 45, we have decided that we only do 3 to 4 of those in an 8-hour workday. So you're talking a total of supposedly 2 hours and 8 hours of working. So then the other 6 hours, or 5 hours if you're me, you're in the pod, or we call it the workstation. And so I'm sitting right there, and I may be documenting or working on a special project or something. But I'm visually, it's like the providers at first kept forgetting that I was there. So I'm kind of, as patients are being walked out, I have one doctor in particular who, oh yeah, I want to introduce you to Steph. She's a member of the team, and you know, she's an expert in whatever ails you. So being visible is really good.
You guys have mentioned teams and working in teams, that it's not just the provider that has to be a part of this, it's the whole team buy-in. Can you talk about how, besides the behavioral health provider and the medical provider, who else on the team is making this successful in your sites?
Receptionists. For sure. So receptionists in my office are key players in this, because there's an intake process or an enrollment process where they prepare whatever screening questionnaire pertains to that patient's visit for the day. And so they do all of the check-in, you know, procedures, prepare every patient, which is quite a few in our offices, and all the questionnaires that she listed out. And then that goes back to the MAs, and the MAs enter that data into the EMR system so that the providers will have it scored and ready to go when they go into the room. And so we have a great EMR system that works really, really well. We use Athena. I don't know what everybody else is using. So everybody has an important role in this, for sure.
I totally agree. From the time they have check-in, and the receptionist, you know, can give me, you know, a feel of if they look really anxious, if they feel like they need attention sooner rather than later. How early the person arrived for their appointment is always interesting. To the MAs who are doing the screenings in the rooms and getting their read on patients, and them relaying that information to the medical providers. It's really a team effort throughout the whole visit for all patients to make this work. And I think that's something that we're learning as we go, is how informed like the front end staff is of what we're doing, why we're doing it. So if there's questions that come up to patients, they'll be able to answer them as well. So it's just a large team. You have to rely on one another.
I probably should have said something about this when I spoke, but I didn't. I just didn't think of it till you guys started to talk now, which is if you have a big patient panel, a really important thing to do to have the whole team involved is to either have a daily huddle in the morning before you start the day, or debrief before lunch, or debrief at the end of the day. So at St. Mary's, at the residency in the morning, there's 2 psychology fellows, and every morning they sit down with the behavioral health faculty, and they look at every patient who's coming into the clinic, and that's lots of patients. That's 20 to 30 to 40 patients. Alex was one of those, so she's nodding in the back. So they look at all the patients with the behavioral health faculty, and they say, who are the ones who have mental health issues? Who are the ones who have behavior issues? Who do we need to be aware of? So that's what they're doing in the big St. Mary's Family Medicine residency that has lots of people. Then where I work in the collaborative clinic that has a smaller patient load, I've been there long enough, so I kind of know what's coming up, but I train fellows as well, and so we'll go through the patients. We also have a health educator who does expert training, or who's an expert intervention specialist, so I'll go through with that person, and I'll say, okay, this person has substance use, and then we have our health educator / expert interventionist will then do that piece, and then we debrief at the end of every morning and every afternoon. And the debriefing allows time for the continuity of care, for the patient reminders, for the staff reminders, for the referrals, for the, make sure that, we get that prescription for whatever in. So as far as talking about a team, we've talked about doing that at Diane's office, and it just hasn't worked out. But that's a great way to have continuity and to not be repetitive and have 2 people doing the same thing with patients, which sometimes happens. So, thanks.
Can I add something to that real quick? If you have the ability in your office to do, like Athena offers Athena Text, where you can do group texting, I don't know. If you have the capability of that, several of my providers have a huddle group, and they list all their providers and what they want on every patient. That's really nice because the front desk people can refer back to that all day, the MAs, whatever. Ask questions, that's your line of communication throughout the day. It works really, really good.
That's great. So you're hearing this theme of using your IT as a team member, right? So how does your IT, either EHR or other tools, help your team? Other ways that your team, who else on your team has been really instrumental for the 2 of you, Stephanie and Gregory?
Okay, so for me, the MAs are indispensable. Front desk people are great, but they don't do the screens. In our offices, our MAs do the screens, and we do the patient stress questionnaire screens, which include the GAD and the PHQ-9 and the PTSD and alcohol abuse annually, and if they have a known issue. But there are many, many, many visits that aren't annual and don't meet that. So MAs know to come give me, they just know. But I wanted to talk about the huddle a little bit too. The huddle is really imperative that you just go through the day. We're having a hard time, that homeostasis thing, we're having a hard time getting away from looking for behavioral health issues and mental health issues. We're trying to start looking more, also for BMI and smoking and diabetes and hypertension and other, health issues that we can help with. But because of my training and because of the doctors, I just need to ask the MAs to help me remember that I'm not just there for mental health purposes, health behaviors as well.
I second the motion about using IT as a team member. All of those screens that we have now are just tableted. They get done. They get dumped in direct. So basically, this stuff is all just automatic. So the MAs are there to say, hey, listen, this guy said he wanted to kill himself. Just make sure you look at that. Important. But other than that, though, it's already happening. We do some huddles. We're probably not as good as we should be. We're very communicative with our EHR and with each other during the day. So that kind of has worked well for us. It's not going to work the same in every office. We also have a call her our chronic care nurse, but so like it's any kind of care coordinator that you might have, but she's got also the medical background and the clinical experience, and so she works with a lot of medical issues, but you know, medical issues concomitant with those are lots of mental health issues and behavioral health issues, and so she's enormously important in terms of helping kind of keep everyone in the orbit and sort of being a center to all the spokes that are out there.
That's great. So every clinic that has an integrated behavioral health presence realizes that they can't do all behavioral health services for all their patients. The demand far outstrips your supply of services. How has your clinic actually determined when to say, nope, we're not going to do that, or we've given enough, we can only go so far with this certain type of patient, or so many visits? How does your clinic determine when you need a handoff to a community provider?
Well, using the doctor's or the medical provider's discretion, they decide who they'll refer to me, who will have a warm handoff, depending on how critical the need is. And then I'm really fortunate because I'm employed by the Center for Mental Health as well, and we're literally 2 blocks apart. And so whenever I need backup or I have something going on, I can try to reach out to my colleagues for support in that way. So really fortunate, and I was going to mention them as another part of my team because I do have access to the psychiatrists and all the mental health therapists in the crisis unit as well. So I feel very fortunate about that.
You mean all the many psychiatrists that are out there?
Yeah.
Teeming masses of them.
Masses of psychiatrists, that's a scary thought. Oh, so I just forgot. What did you just say?
So what if when we're done with them?
Okay, yeah. I knew I had a thought, and I picked up the mic for a reason. Okay, so with the informed consent, within my spiel and even on my paperwork, it says that if you have need for any more than 6 sessions, then we will help make sure you have a long-term therapist, a specialty mental health therapist who can address your needs. When I know after just that first session that I think I'm going to be making that referral, by the end of the session, I'll give them the list, the Center for Mental Health open access hours, and I'll explain that you and I can do some work here on some of the topical issues that are just here and now, and yet I'm not able to, with this in this setting, provide you with some of the trauma therapy that I would like to, because I'm trained in trauma therapy, but I can't because I'm an integrated health counselor now. No, I'm just teasing. I don't say all that to the patients, but I'm EMDR certified, and I miss that. That's what I miss from private practice. Okay. But it's part of the very beginning. You set the expectations and you manage the patient's expectations.
But you know, I'd say that's a hiccup, and that may be a big hiccup. That's a problem because people become accustomed to, you know, integrated care. They like being able to get services in the same place. They talk to the same people on the phones. They know the same people in the office, and it's true, I never feel as comfortable sending people out. I mean, the Center for Mental Health, where we are in both Delta and Montrose, are great, but we still feel detached. We don't really interact a lot. Now, both of we're collaborated with the centers, so that can help. So if they're saying we can't help you, our providers can usually reach out to people in the community. I know wellness is here, and like we try to reach out to people if we can, but I'll tell you frankly, I mean, that is a problem. A lot of times I end up being a de facto, like, you know, mental health provider. I do a lot more mental health than I ever thought I would. I prescribe a lot more, you know, mood stabilizers and anxiolytics and all of the above, because people feel more comfortable. And there's you know, in terms of prescribe, I know there's some of the prescribing folks from the center, but they're overwhelmed. I mean, it's not easy to make it happen, and so we're all sort of struggling with how to balance that.
So that's a tricky one. Our patients don't want to let go of our providers. They want to only see them. But it's provider discretion for when it's time to send them off to somebody else, but they always wind up back at our office. And so that's one of the reasons why I feel like we should do more, is because, well, it's always we should do more, you know. But so we
It
can
doesn't
keep
seem
our
the same
patients.
way, just like you're talking about putting medical providers in the mental health setting. I mean, the whole goal is that we're so siloed, and that maybe that's the future. The idea is it can be in different degrees, but the idea that everywhere you go is to some degree integrated. That's I think that's where we all believe that the ideal lay.
Barbara can remember some of the initial stakeholder group meetings when they're like, well, maybe we should train our baristas to ask about suicide. I don't know if we're going to go that far too soon. So now I've asked a lot of questions, but I think that the audience has probably better questions. So who has a burning question for the panel?
So there are obviously a lot of folks out there who need services and fail screenings right and left, but I'm sure you have people coming through who don't. And you said, you know, all those screenings, it's within a year sometimes, but do you have any pushback, people who are annoyed by all, whether it's tableting or on paper, and having to fill out a screening every other time they come in and are not thrilled about that? And how do you handle that?
Okay, I just want to address that. So, so I've had conversations with our MAs who do the screens, that if you're getting pushback, just say then that's all right. You don't need to do that. But it might be useful for you to be introduced to a member of our team, and so then I can do a 5-minute conversation that is sneaky, because I end up getting all the answers to those questions and I can write them down. And but we when somebody's annoyed, we actually say, okay, you don't have to do this. This is for your health, but it's not mandatory.
I just say, so we're in the same business, and I'd say a very small fraction of the times that I go and seek out my behavioral health therapist have to do with a positive screen. The vast majority of them are on visits that are not annual visits, are not screenable visits. They're there, again, for sometimes a stated reason, but sometimes it's something completely different. And that's where, with all of us, whether it's the first person who says hi on the way in the door, the people in admin, the people who are MAs, whoever, everyone has to kind of be in tune, because I agree, it's a team. We say integrated in this behavioral health, but it's the whole system. It's every part of it. And I try to pay attention, and hopefully the people around me who are working with me pay attention. I think that's where the rubber hits the road most of the time.
Yeah, I agree. Most of the referrals are the handoffs are not from the screenings. And then if there is pushback or resistance, I guess I kind of have a fun way of going about it, trying to talk to people why the heck they're coming to see me. And it goes something like, somewhere along the way, some brilliant person figured out the head's connected to the body's connected to the head, and what affects one affects the other. And so I hear you're having difficulty sleeping. Let's talk about it. So I seem to go really fast, and they get really...
Their head's all turned around, and they don't know what to think.
Absolutely. So that's how I go about it.
So we've only visited one practice so far, and that was Thyroid Medical Center. And I think what they do is they use a 2 questionnaire, and if they're positive on that, then they use the 9 questionnaire to keep the question numbers down. Do any of you here in the room feel like that might be missing patients? But it sounds like maybe that's not that much of a concern, because that's not where they're necessarily being identified.
Yeah, I think there's a noise to signal ratio problem eventually, right? With so much stuff, if you're in primary care practice, there's a huge burden in terms of screenings you're expected to complete, things you're supposed to ask about this, and it just overwhelms you. And after a while, it's almost like you're rote just going through the motions. And I agree. We've talked about that in our practice. How can we, it's like it's like the number of clicks in an EHR, right? You're always trying to reduce it. Like, how can we reduce it to still be somewhat useful? And I don't know. Do any of you have an answer?
So this is a different perspective, I guess. In my clinic, we do a lot of screenings, and for teens, we screen them every 3 months. Partially based on some feedback from other conferences, and then a patient who actually requested to be screened because she wanted to report something, break the ice, so it could be addressed without telling her mom, without having to say it out loud to me. So we screen pretty frequently. And I think the flip side, and a big kind of umbrella concept in health, is preventative health, primary care. And so it does give you an opportunity in primary care to see a negative screening and applaud that, or tell the patient or the teenager you're making really good choices. So it can go both ways, I think, in my experience, to catch a problem and to potentially find a way to highlight something that's good and give someone some good feedback.
You can tell my wife is more patient with these things than I am.
Good. Other questions? Oh, sure.
I mean, I think at the end of the day, a screening is a piece of paper. And it's very relative, and it's different for everyone. Everyone has a different baseline of their PHQ and their GAD. And so it's about building relationships. So if you're only doing the PHQ2 and there's 2 questions, but the MA has met with them and they were tearful with the receptionist, that's what matters. It's not what their score is. Yeah. So I think it's just keeping in mind that we all are doing what we're doing because we care about people, and to not let screenings run roughshod over your practice.
Unfortunately, pragmatism sometimes carries the day because we get paid extra for doing these screenings. So it turns into well, we think we're doing good and we're getting paid, and we'll stack them on each other. And so, yeah.
Yeah, that's tricky.
I think that, just to comment too, is I think that it also opens the door for medical providers to start having that conversation. If the screening's been done, it gives them the opportunity, both the patient and the provider, to start having that dialogue that might not happen any other way.
So speaking from the patient perspective, I've been to primary care practices where I've been positive on the Q2, the 2 question, then received the 9 question, go into the appointment. Very disappointed that it was not brought up at all during the appointment. Oh. So to hear that you're reimbursed better by screening makes me wonder if that's what's going on, that there's several practices they're doing screening and then don't do anything further than that. And that's very upsetting from the patient perspective. And so I'd just encourage any providers that making sure that if you're doing screening, you know what to do with that information.
Okay. Yeah, and just to be clear, hopefully that's not what we're doing. But there is that, but like all things in medicine and in healthcare, there are perverse incentives, and that one is well-intentioned, but perhaps not perfect. Again, your EHR, typically, there should be a rock-solid, hey, this is a positive screen. Like, we have basically a positive and negative, cutoff. Yeah, you can look into it a little bit more closely, but, I address every positive. Unfortunately, the way some of these things are worked out, all the kids say they're suicidal, but it's because it's yes/no questions, and then it flips in the last minute.
Yeah, it's tricky.
We don't use the PHQ2. We decided to just go with the PHQ9. You should talk to your provider office about what happened to you, though. But we do lots of postpartum screening as well. And so I think this is a really deep topic with screening questionnaires, for sure. But they're heavily utilized. I collect data on them constantly and use that data for, all kinds of things. So I do think that they're being looked at and they're being viewed, and we do overdo it sometimes, so we back off our patients if they're upset about it, and then the providers kind of deal with it and always can get them to do it.
Good. Other questions? Oh, back here. I should have stayed there.
Mm-hmm. I just wanted to add a comment. I worked in the SLUD clinics, and one of the huddles that was very useful for us as we reviewed, we also did review the patients that were coming in that day, and we had the good fortune of having some doctoral students on board that had extra time. So that was a privilege. However, one of the risks that we were looking for is complex medical problems, as well as the maternal, the OBGYN concerns, prepartum, postpartum. And so some of the flags that we had were really consistent with our outcomes on screens. And also, we tracked that outcome data over time, and so we had additional flags for those who, over the years, were kind of consistently either coming into crisis or had a significant pattern. So.
Good point.
Great. That's a great way to go. Depression plus another comorbid illness doubles the price of that comorbid illness for the next year. So just thinking about the cost drivers when you're looking for return on investment, that's a great way to risk stratify your patients.
I guarantee, listen, and the flood of screening tools have come online, I think, without proper education for practices and physicians. With a lot of times, so now we do the postpartum depression screen, but we had this big problem. We said, well, we see these women before they go to see their OBs, right? And first day, I get a positive one, and well, what do I do? And so we had to come up with a system of approaching our behavioral health therapist and just having her touch base. Or sometimes you can actually, if you feel like you have a relationship, you can have a conversation with them. But I got to admit, I almost don't want to look at it, because what do I do, if they're depressed? But the point is, I think, really salient that if we're going to do these screens, we need to, it's like any test you do, you need to know what to do with it afterwards and be consistent with it.
All right, so there's a big old elephant in the corner over there around paying for this that I'm absolutely shocked that nobody actually asked it. So I'm gonna ask it. How do you pay for this? And does it cover all the costs? Or if it doesn't cover all the costs, what are you looking for that value that proves its worth? I think on that last point on one of the slides today was, how do you prove your value? So how do you pay for it? And then how do you make up that incremental difference in value with your clinic?
Well, so again, someone who really spends a lot of time having to, look at the numbers, right, and then justify things to my partners and keep the practice running. I think of it. You can think of it in many ways. One way is, when is a good capital investment worth it for you, right? When is buying that really expensive printer better than going cheap? Right, never. So some people will go that route, exactly. So I think we've almost, just in a really sort of cold calculation way, we've decided our practice runs better with a behavioral health component, period. Now, when do we cross over that line financially? Because, we're not seeing down the road immediately an obvious way to deal with paying for this, okay? They're still siloed. We're still siloed in terms of how we pay for mental health services versus other health services. There are attempts to make that work better, but it's kind of trivial. So I think we think of it more in terms of how the overall practice feels like it's running. But I can't go back and then justify it.
Our providers are more productive, so they're doing more billable patient. They have more time to see more patients because I'm dealing with the folks who are crying and who have family dynamic issues, and I'm rescuing providers right and left. Okay, I'm exaggerating.
You are.
Okay, I feel like I'm helpful, so we make more money when we're there.
I think grant funding and stuff is always an option, but it will run out. And so we've continued to search for different options. Families Plus has really paid for themselves. We're really not out anything for them. But it's totally worth it even if we don't make anything, because it's been so beneficial to our practice.
Well, I don't get into all the financials, but I'm very fortunate that there's two organizations willing to support me through Gunnison Valley Health. It's a priority, and they've put money towards my position along with the Center for Mental Health. And I do long-term or longer-term mental health as well for revenue through Medicaid, which does help offset some of the costs, I believe.
Yeah, and I'd say as someone too who also, another hat I wear is being involved in broader, bigger medical contracting with Medicaid, Medicare, not so much with PEDS, and other private payers, and grant-funded organizations or grant-funded programs. The movement is to pay for quality. And one of the ways we demonstrate the quality we're delivering to our patients is by saying that we have an integrated model. Now that can involve dental, it can involve behavioral health, it can involve a lot of different things. But we actually probably, when you look at some of the programs that we're qualifying for are partly due to having integrated behavioral health. So I guess I'd go back and say that probably we might be making it up on that at least. Yeah. And it's the future. Like there's no doubt that in 10 years that's the goal. So I don't feel bad about investing in it.
I think something else, we haven't been measuring it, but getting feedback from providers that this person used to be on a monthly callback and they would come back within 3 weeks or something, and now after participating in the integrated behavioral health, they're on a 3-month callback. So definitely changing the quality of their life if they're not having to go back to the doctors all the time. So
awesome. Great. Well, I want to. Oh, do we have time for one more? Or am I? Okay, last question.
So I just wanted to speak to how some of these are being funded in that, in collaborating with the Center for Mental Health, we do have those capitated dollars through Medicaid. And so we're able to have our clinicians do enough billable hours that we're able to show and use those Medicaid capitated dollars to support the position. And then we also put, the not reimbursed amount, but to share or take the burden to provide those.
And I think what you're speaking to is, here's a perfect example. We have these two competing sort of silos. And so, the center wants and needs to get theirs, right? Yeah. And we want and need to get ours, but the two don't really relate to each other, and so we're always stuck in this: are we collaborating, or are we sort of fighting for each penny on the dollar? And that I wish would change. Okay. Yep.
One of the interesting things just to watch is with ACC 2.0, the new Medicaid program, where they bring both of those groups into the same organization. That the capitated group has to be the same organization that runs your medical services too. It'll be interesting to see how that shifts and when and how. So let's give a round of applause for our panel.